Hi everyone, my name is Riya Gosrani and I'm a recently qualified medical doctor. My supervisor, Dr. Paula Sheppard, is in the audience and she supervised me during my Masters in Medical Anthropology at Oxford last year. In my talk today, I'm going to be talking about the race coefficient and how it's being used to perpetuate racial discrimination in the diagnosis and treatment of various conditions. And I'm going to be looking specifically at chronic kidney disease, or CKD. Now, despite this being abolished, the race coefficient in many hospitals today, it continues, its effects are still lasting, and I'm going to describe these lasting remnants using a new concept that I've termed the statistical looping effect, and I'll go into that later on in my talk. But essentially, we're going to be proposing a paradigm shift to a life history theory approach so that we can dismantle these harmful medical practices. But the problem is that evolutionary medicine perspectives are rarely taught or utilised in medical schools, so our aim is to hopefully shift that perspective to that sphere. So just a quick background on kidney disease. Chronic kidney disease is essentially a condition where there's a progressive, gradual decline in kidney function. And on the board, you can see that GFR shown in black, that stands for glomerular filtration rate. And that's the equation that we use to diagnose and stage patients into different severity levels. So a GFR of 90 or higher would mean that it would be sort of stage 1, so that would mean that the kidneys are healthy and working well. And then on the other end of the spectrum, when the GFR is less than 15, that would mean that the kidneys are failing. Now, the GFR equation is really important, and it's basically the reason why the race coefficient was implemented, because it takes into account a waste product called creatinine, and that's just a measure of how well the kidneys are functioning. But I'll go on to explain why that has led to the incorporation of this race coefficient, which is really, really problematic. So essentially, with the score, patients are placed into different severity categories, and the GFR equation was constructed in a study in the late 90s, which had quite a small sample size, so about 1,500 patients, and of those patients, only 12% were black. And the researchers found that black patients had higher creatinine values than the rest of the population, and this led them to come to a conclusion that the black race is representative of patients having higher muscle masses and therefore higher creatinine values. And this is what led to the incorporation of the race coefficient. Now, what this meant was that for decades, as a result, the race coefficient was incorporated, and physicians basically have adjusted the GFR of black patients to higher values than non-black patients, so their kidneys are seen to perceive at a higher level. And I hope it's obvious that it's a really flawed conclusion that they came to, but it has been used for decades in medical practices. And the reason why the stages are so important is because the stage to which patients are assigned determines what treatment they receive, whether they have access to nephrologists, so kidney specialists, and so on. And we're about to see what the effects are. So I took this screenshot from a website called MD-Calc, and just to put this into perspective, on my first day as a medical student, one of the doctors told us to download this app onto our phones before we even saw our first patient, because it's so crucial in calculating algorithms and scores. And as you can see on the left, so I basically selected the same characteristics, so 2 females, 60 years of age, and with creatinine values of 220 micromoles per litre, remembering that creatinine is what's used to calculate GFR. Now on the left, I selected no for black race, and that gave a GFR of 19.7. And on the right, I selected yes for black race, which gave a GFR of 23.9 millilitres per minute. So this is the race coefficient live in action. And the reason why this is so important is because if you look at the National Health Service in England, kidney transplant guidelines, we can see over here, so I've highlighted in green what physicians are told to do. So we're basically told that you can only consider a patient eligible for a kidney transplant if their GFR is less than 20. So you can literally see that on the left-hand side, the non-black patient has a score of 19.7, despite having the entire same demographics as a black patient, and they would be considered eligible for a kidney transplant. Whereas the black patient on the right has had this adjusted score, which has basically meant that they're not going to access the same treatments as non-black patients. And I took those screenshots just a few months ago, so last year, Now, interestingly, MD Calc has now put a statement on their website which actively discourages and speaks about how problematic it is to use skin colour, first of all, as a proxy for race, and also what this audience would be quite familiar with. So the huge variation of genetic material makes it really difficult to categorise patients into discrete racial entities. And of course, this is really positive because it means that we're now not using this anymore, and in the UK, a lot of hospitals have abolished this practice of categorising patients by their race. However, these conversations have been going on for years within the evolutionary medicine community and in general. So the fact that hospitals are only now just starting to make this change does show how slow this pace of change is and how behind we are. Okay, so I think also the fact that we are starting to make a change now also represents a crucial moment in which I want to monopolise on this change, and now the fact that people are talking about this, I think that we can really use evolutionary medicine perspectives to try and further dismantle these problematic practices, which don't just affect kidney disease, but many other conditions in medicine. So I'm going to introduce a new concept called the statistical looping effect. It's a bit of a mouthful, but it's basically been adapted by a philosopher called Ian Hacking, and he came up with the term looping effect. Now, I've added in the word statistical, and I've added this to race, to basically account for the ways in which statistics have gained power through medical practices which marginalise Black patients. So I'm just going to explain this a little bit further now. So after removing the race coefficient, studies have now found that disproportionate numbers of Black patients are receiving dialysis for kidney failure. So that's a treatment which involves taking someone's blood out, filtering it, and returning it to their body. Now, I would argue that this should simply allow for a consideration that the initial race-based equation mistakenly placed Black patients into the wrong category and subjected them to poorer health outcomes. So these disproportionate numbers are just showing the treatment they should have been receiving in the first place. However, some studies are now using these statistics to basically, so the statistics demonstrating inferior kidney function in Black patients are now sometimes being used to justify the very racialised medical practices which subordinated this group in the first place. And that's why I'm describing this as a statistical looping effect, because the statistics have gained power via the medical practices which are intrinsically racist, and they're able to repeatedly marginalise Black patients. And this is why I'm saying that it's not enough just to remove the race coefficient, because otherwise these harmful practices are just going to continue. And so I'm going to turn to this diagram, which is really widely known now within social science spheres, but I think it really demonstrates my point very well. And if we look at the move from equality to equity, I would say that that represents removing the race coefficient. So if we look at the patient on the right-hand side of the equity box, that can maybe represent a Black patient who was previously unable to diagnose dialysis or kidney transplants due to misdiagnosis. Now they can access the same treatment as the patient on the left-hand side of the equity box. However, they still have to climb 2 more boxes than the patient on the left. And that might represent the years of misdiagnosis, the years in which they weren't receiving the treatment which they should have been receiving. And so if we now turn to liberation, that would represent removing this all altogether. So removing the race coefficient, whether we have a GFR equation with or without the race coefficient, we can see that inequalities and inequities still persist. And that's where I turn to an evolutionary medicine framework. So looking at life history theory to try and reframe how doctors think about disease. So I'm not going to go into the depths of this because I think this audience is quite familiar with this, but essentially, if we look at racism like stress as a metabolic burden, and if we start looking not just at the point at which people are diagnosed and treated for conditions, but looking at the intrauterine effect, so thinking about the nephron development, so the development, so for example, if a mother has experienced racism, what is the impact on the nephrons, which are the functional units of the kidneys, and then how does that go on to impact patients later on in life? And that would then beg the point that it's too late to start intervening once we start looking at diagnostic technologies and treating patients. We need to start thinking about the intergenerational ramifications of racism, which is so apparent but so rarely talks about within medicine. So our aim now is to catalyse action within the medical community, and evolutionary medicine perspectives are really good at transcending this individual level. However, as I mentioned at the beginning of the talk, I've not been taught about evolutionary medicine in medical school, and these kinds of perspectives are really rarely implemented in patient care. So we're now turning to you to hopefully maybe offer some suggestions or solutions about how to implement these approaches and how to bring these perspectives to medicine to better patient care and hopefully for future generations. And our proposal basically encourages researchers and practitioners to address the root causes of inequalities rather than relying on flawed tools such as race coefficients in diagnosing and treating CKD. Because, as I've hopefully demonstrated, using the statistical looping effect, even as we move past the race coefficients, the inequalities are still lasting. So I just want to say thank you so much for listening, and Paula and I would love to frame this in a medical journal later on this year. So if you see us later tonight or tomorrow morning, I'd love for you guys to come and talk to us. Thank you so much.